Okay, well, thanks again for the huge task of following these two guys. What is there left to say? So, I was asked now to talk on how to monitor MPN patients. And we've heard a lot about what aspects of disease we're looking at, our aspiration for how we would really like to measure symptoms. Very difficult to incorporate that at the moment into clinical practice, and something we should really work hard with you guys to be able to achieve. But also then from Carlos, all those amazing algorithms and thoughts and lessons on the microscope. Really very nice. So how to monitor patients. So we know that MPNs, as we think about these diseases medically, we've heard about what does the blood count show, what are the things that we're thinking about in terms of complications, and I've tried to summarize these on this slide, but also important to put across other aspects. So quality of life beyond just symptoms, thinking about toxicities of medications, and Yvonne, who is a great friend and colleague of mine, is going to talk on that later today. These are all things that we should be monitoring with our patients. So I've tried to put these aspects on this slide, which you had a sneak preview of earlier. But these are all things that we should be thinking about, and we're trying to think about when we're monitoring our patients. And when you're visiting us, these are the things we are wanting to really understand from you. It's quite complex to think about putting these across in a medical consultation. Increasingly, as we're busier and busier, the health economic environment, certainly in the UK, is quite tough. So we have 10 minutes to monitor a patient, to prescribe, order tests, etc. So quite tough. When we're thinking about treatment, just to reiterate the type of treatments that we use, and again, apologies if you don't agree, but trying to group together ET and PV, are thinking about risk and our then stratification of treatments. So for low-risk patients, we're thinking about aspirin, keeping you healthy, listening about symptoms and watching for evidence that we need to change that strategy. If you've got PV, we're also thinking about phlebotomy. If you've got high-risk disease, and we discussed how we risk stratify yesterday, we would be thinking about high-risk disease as enlarging spleen, increasing white cell count, uncontrolled symptoms, but there's no real medical guidance on what uncontrolled symptoms really means. Intolerance to or high need of phlebotomy, or, for example, an event. And then these are the kind of drugs that we're thinking about using in standard practice. I realise that JAK inhibitors are available variably across our countries, but it's still probably not standard practice, at least not in the first line for management of these conditions. So if we're thinking about if a patient is not adequately controlled, these are the kind of things that we're wanting to be thinking about. And I would encourage our patients and our patient community to understand that these are the things that we're looking for as clinicians. And really, I encourage my patients to become experts in their condition. John's just checking that he's clocked all of this. Yeah. I always like to give my patients a copy of their blood results. Some patients don't like that, but I really like to make sure, if they want it, that they have a copy. But of course, then there's a lot of questions. There will be less questions now if they had the chance to listen to Carlos, but there are always questions about what all the little abbreviations, etc. mean. But these are all the things that we're looking at monitoring for our patients. Is the disease well controlled? Is it progressing? Is the treatment still appropriate? Does my patient still understand their disease? Do they have any residual questions? Have they been listening to anything that's raised additional questions for them? There was a very striking presentation about 2 weeks ago from Mary Frances McMullen from a study that MPN Voice helped to support called the Mosaic Study. And in this study, which was primarily aimed at looking at epidemiology, i.e. why do patients get disease, and I would recommend that you, if you have the chance, that you listen to one of her talks. They also did a series of other things. They took the opportunity to measure symptoms in patients and controls, and were able to work with Ruben and show really conclusively for the first time that MPN patients have a worse symptom burden across the spectrum of the different MPNs than age-matched controls. But they also did a really interesting thing, doing like an exit poll from clinic of patients that attended the 2 hospitals that were involved. What do you call your condition? Do you call it a cancer? Many of you, we've had a lot of discussions about cancer, neoplasm disease disorder. What are the aims of your treatment? And it was quite striking for patients going to 2 quite large hospitals in the UK that many of them didn't recognise that they had a blood condition, that they had a blood cancer. They didn't know what their disease was called, let alone that it belonged to a family of MPN. So these are huge issues that we need to get across in clinical context. We're also checking symptoms and quality of life, thinking about side effects, and thinking about other changes in our patients' health or vascular risk, as well as building that therapeutic relationship, the trust, the mutual trust, the feeling that there can be mutual openness, and a forum for frank and honest discussion. All very important. So I want to tell you some patient stories now, because I always find that these are a very powerful way of putting across what kind of things we're looking at in our clinics. So these are fictional patients. So here is a patient, age 59. He's a man. He comes with an incidental finding of a raised haemoglobin. This is a very common way for patients to present. And here you can see his blood work up. He's got a high haemoglobin. His hematocrit's quite normal. White count's normal. Platelet count's normal. He's had a marrow. It shows trilineage hyperplasia. That means all the different types of red blood cells are increased. Increased number of mature megakaryocytes of varying size. I should be able to test you all on that now. You saw some beautiful pictures. The patient has blurred vision and severe headache. He has molecular analysis in our clinic. That's done actually at the same time as the blood count. It's sent to the lab at the same time. It takes a couple of days to come back, but we do this test up front. So this patient has a diagnosis of polycythemia vera. And because at that time he's a low-risk patient, he gets treated with phlebotomy and aspirin, and that happens for around 15 years. So this is very normal. Clinical assessment after in a clinic, at that time the hematocrit is not well controlled. 52%, not good enough. 4-fold increase in risk of thrombosis with a persistently elevated hematocrit. White count is good. Platelet count's good, hemoglobin matches the hematocrit, spleen is now enlarged. So patient gets switched to hydroxyurea or hydroxycarbamide, takes a relatively small dose, so there's sometimes a lot of interest in what dose of these drugs we use. It doesn't really matter about the dose in terms of disease severity, but this patient takes 1 pill 5 times a week, is reviewed again multiple times. Usually stable patients on this drug in my practice are reviewed every 4 to 6 months. But he then has what we call thrombocytopenia. That means a low platelet count, and the dose of hydroxyurea is reduced. He's taking it 3 times a week, but he then needs phlebotomy 6 times a year. What does that look like? So it might look something like this. Multiple visits, and then the dose of hydroxyurea is reduced, and all the time this patient's hematocrit is over this dotted line, the patient is at risk of having increased risk of having a thrombosis. So the question to the clinician, is this disease adequately controlled, includes, yes, this risk of multiple episodes of being at risk, increased risk, but also the thought that this poor patient has to come 6 times a year and take at least half a day in a hospital having a pint of blood taken off. Many of my patients have to take a day of holiday to do this. So that might be up to a quarter of their leave allowance from work to attend the hospital. So this may well be very acceptable, or it may not be, and so there needs to be some conversation with the patient with regard to this. But Carlos Beces, who's sitting on the podium, his group and the Powerful Spanish Registry have recently shown that for patients who need up to 3 or more phlebotomies a year while they're still on hydroxyurea are at increased risk of thrombosis. So this is a kind of marker that we should be thinking about in terms of changing management. Changing management might be increasing the hydroxyurea, or it might be, for example, switching to another agent, or just being more careful that the time above that line isn't so high or so frequent. Here's a patient with a diagnosis of ET. This is a man who presents with stable angina. Remember I told you, you men, you're at more risk of arterial thrombotic events yesterday. So this patient has stable angina and somebody notices that the platelet count's high. So about 20% of patients, when we have them at diagnosis, have already had a thrombosis event in the years preceding the diagnosis. So this patient would fall into one of these categories. This patient's bone marrow, well, I can't fit all the words for the WHO in, but basically the patient has increased numbers of the staghorn-like, very mature, beautiful megakaryocytes that we see in ET. He has no symptoms at that time. Mutation analysis, JAK2 positive. We often wouldn't go on at this point and check for CALR or MPL because it's very rare for patients to have both and it wouldn't alter our management. So this patient is a young patient. In my practice, I offer patients a choice: hydroxyurea, interferon, or anagrelide, although this would be off-label use of anagrelide in Europe because it's approved for second line. Elsewhere in the world, anagrelide is more widely used. This man chose interferon. He had this treatment, like many patients did, with a standard interferon, quite a high dose, clinical assessment after 10 years. White count's a bit high. That's probably high enough for me to get concerned. Platelets are okay, hematocrit's probably okay, patient feels depressed. That's probably interferon toxicity, but of course in the context of the clinical conversation we'd be thinking about other matters as well. But certainly enough for a patient that's taking interferon. If we think it's drug related, if we think it's anything more than a minor depression that we can't manage, we'd certainly be encouraging the patient to think about having a holiday from drug. This man can't have a holiday though because his white count's up, so his disease is not well controlled, so we had to make a change and he chose to change to hydroxyurea. Unfortunately, he's still got problems with a raised white count and he's now got a spleen appearing. So for this patient now, I'm wanting to look at his blood film. For my patients, I tend to look at a blood film twice a year, and I would generally at least once a year put a hand on their tummy to see if I can feel a spleen. It's not always necessary to do an ultrasound in order to do that, but sometimes it's not easy to examine a tummy. The spleen's very irregular. It's difficult to be consistent about measurement, so we do sometimes use ultrasounds. So this is a patient where we would be really thinking about, has their disease changed to myelofibrosis, for example. What about myelofibrosis? Well, this slide goes backwards and forwards between many of us. I think it started with Ruben, it's come to me, it's gone to other people, it's come back again. This is what we think about in terms of monitoring and managing patients with myelofibrosis, whether they've got primary myelofibrosis, post-ET or post-PV myelofibrosis. Carlos mentioned the rather difficultly and clumsily named entity pre-fibrotic myelofibrosis, a bit of an oxymoron. There we go. Whether we should manage those patients like patients with ET and PV, or whether we should manage those patients like MF patients, we have to sort out. Very difficult, because certainly the behaviour of that disease is a bit worse than ET, but not quite as bad as standard myelofibrosis. Maybe it's a bit closer to PV anyway. So generally for myelofibrosis patients, we're calculating risk score. You should know how to do that by now as well. And we're assessing symptoms. We're calculating a risk score so that we can think about transplantation and decide about that. We had a discussion about transplant yesterday. I'm sure it'll come up again today. And then we're trying to identify which target thing we want to manage for our patient. And so we then switch from prognosis to clinical need. Is the patient anemic? If they're anemic and I think they need management, I might choose with them one of these agents and or just intermittent blood transfusion. If they've got splenomegaly, well, we had a revolution in management of splenomegaly, and most of us would be able to use ruxolitinib for that. Constitutional symptoms, quality of life, many different potential interventions for that. Ruben leading the way, interventions with regard to yoga, interventions with regard to wearing a Fitbit, interventions with regard to group therapy. We use a fatigue service and psychologists and occupational therapists in our service. So each of these things we might choose for our patients. So it's a little bit more difficult to show you a standard patient story for myelofibrosis, but we're going to have a go. So another man. I don't know why I picked all men for these patient stories, but there we go. So this is a man, 66, referred with a big spleen. That's a common route for patients to come in with a diagnosis of myelofibrosis. Somebody finds a big spleen. This patient's got a mild anemia and a slightly low platelet count. Because of his anemia, we measure the EPO, which is the hormone produced in the kidneys, which triggers red cell production, because this is useful for us in terms of deciding as to whether EPO will work for the patient. The marrow was compatible with MF. Again, he's JAK2 positive. Symptom assessment, he's itching. Sometimes patients don't recognise itch as itch. Sometimes it's called a prickly feeling or a tingling feeling. So I've learned to ask about, how does your skin feel? It is not always aquagenic either, not always after a bath or a shower. Tiredness, really common, really, really common. Feeling generally abnormal. So this patient, pre-2010, we didn't have very much. We decided to give him hydroxyurea because we believed it would be good to try to suppress the clone, suppress the spleen. After a year of hydroxyurea, the spleen is much bigger, fatigue and itch is worse, platelet count's lower, hemoglobin's lower, patient is sweating. Patient is not doing well. And at around 2010, we began to enroll patients into the Comfort 2 study. And happily, this patient is one of our Comfort 2 patients. Here's the spleen, here's the liver, this is the kidney, it should be over here. It's displaced this way because of the spleen. And here's this patient after some time on ruxolitinib. Put on some body fat, normal spleen, feeling well. But we have to learn to monitor patients with ruxolitinib in a different way. We have to learn to monitor them for this, weight gain, for their cholesterol going up, their blood pressure going up, risk of infections, etc. So we have to change our plan and think accordingly. So just another word on another aspect in the last couple of slides on how to monitor MPN patients. Who is monitoring the MPN patient and where? Who is monitoring the patient? Well, I would suggest that the patient themselves is one of the best people to monitor themselves. They need to, if they're able and willing and want to, and some patients really don't, become engaged in understanding their condition, and the work that your groups do is absolutely invaluable with regard to that. A nurse, certainly in the UK community, we have specialist nurses. Yvonne is one of those. She was one of the first ones of those in this field. She provides an expert, invaluable resource for patients. She's sitting at the back, scowling at me now. The doctor, yes, is important, but the doctor is many different doctors. The doctor might be the gynecologist. The doctor might be the obstetrician. The doctor may well be a haematologist that does a lot of different conditions. So not necessarily a specialist, maybe also be the family doctor, but actually all of them need to be involved. And we need as a community to make sure that there's a way of involving them and educating them. And this reflects also the where in terms of monitoring as well. And I just want to share with you the old view from my office at St Thomas's. I've actually moved now, so I work at Guy's. I don't even have a window. I told you the UK health economy was changing, but there you go. Thanks very much.